So welcome to the July 9th, 2021 Buckeye Scope session. As you've heard us mention, we would love for you to put your name first and last, as well as email address and organization in the chat box for attendance purposes, and rename your screen by hovering over your square into the three dots in the blue box, and you'll be able to type in your first and last name and organization there. Jesse, do we have anybody on by phone? I don't see anyone. Oh.
I'm by phone.
Okay, thanks, Abby. So you won't be able to join us by video maybe, but it doesn't look like any phone numbers are there, so we're good. Excellent. All right, so I want to take a moment to introduce our hub team. We have a new member joining us this week as well. So you are familiar with me. I'm Steph Weber, psychologist in Cincinnati. And then my counterpart, Dr. Andrea Whitwer, is at The Ohio State University, also a psychologist. Elsie Bush is our occupational therapy representative, and Michelle Raleigh-Roberts is actually in Omaha, Nebraska, but an Ohio native. And so she is also a psychologist and trauma expert. John Kinsel joins us as our infant and early childhood mental health consultant and trainer. And then we have Kristen Kerwin, Stacy Lee, and Sue Meeks, who join us from Athens County, Ohio University affiliated, and they are our nurse navigators. We also have Aaliyah Keeley and Troy Hunter, who are developmental specialists at the Ohio State University's Nysaunger Center. And Troy has actually graciously agreed to present a really great case for us later today. We have Amber Clark, who is a licensed social worker at Cincinnati Children's, and Kathy Wedig, who is a newly retired neonatologist from the Cincinnati area. And then we'll be hearing today from Pam Williams-Aria, our developmental behavioral pediatrician at Cincinnati Children's. And then joining us to replace Leslie Razorbecker in our speech-language pathology role is Megan Stahlhut, who has lots of experience with developmental disabilities and currently actually works in Northern Kentucky and Boone County schools. We also have Michelle Hendricks, who's an adoptive mom and advocate, and Joe Mayo, who's our peer support recovery specialist from Marietta Memorial Hospital. And if you joined early, you heard her talking about some of the hard work that she's been doing already this morning. So thank you for that work, Joe. So we are already into session 3. We have covered the opioid crisis, social determinants of health. We've talked about peer support with a really great session 2 weeks ago. We have a change in our schedule for today. Dr. Kathy wasn't able to join us, so Dr. Pam is able to step in and pinch hit and provide us an overview of toxic neurodevelopment with a focus on fetal alcohol spectrum disorder. We'd heard from folks who participated in our last series that we wanted some more information on FASD, so she's going to do that today. And then Kathy will be with us in 2 weeks with toxic neurodevelopment with a focus on NAS and some updated data there. John will present around having difficult conversations in a month's time. And then on from there, we have a couple specific sessions focused on just trauma and infant mental health, as well as just traumatic stress in young children. And then we move into language development. Dr. Leslie will be back for that. And then we have our substance exposure and sensory concerns with Kathy Krebs in early October. And then we will close out the series October 15th with systems, barriers, and opportunities with some of our folks at the state level. So today we are going to do our core didactic and then have some clarifying questions like usual. Troy will have one of us present his case, but he will be on the line to answer questions. And then we'll do our breakout groups, introductions in our breakout groups, talk about our recommendations, and then come back together to share those. As a reminder, we have captioning available. So if you are interested, you would just hover over the CC box at the bottom that says live transcript, and your transcripts will come up for you there. Thank you all again for putting your information in the chat box. And at this point, I will go ahead and introduce Dr. Pam Williams-Aria. So she is currently a developmental behavioral pediatrician at Cincinnati Children's Hospital, but she joined us after completing her pediatric residency at Cincinnati Children's, and that was after she had spent 10 years in general pediatrics. And so she's had a longstanding interest in child development and always practiced in primary care. And so the specialty of DBP was a natural choice. She has expertise in evaluation of autism spectrum and other DDs and approaches every patient and family with respect and sensitivity, and believes in shared decision making and ensuring families are actively engaged in the treatment and care choices. So she also participates as our LEND. You've heard us talk about the LEND program. She's our faculty member in developmental behavioral pediatrics in Cincinnati and trains our graduate students. And she enjoys reading and spending time with her husband and 2 children outside of work. So Pam, I will turn it over to you and let you share your screen.
Well, today I'm going to be presenting on fetal alcohol spectrum disorder, as Steph mentioned. And my name is Dr. Pam Williams-Aria. I'm a developmental behavioral pediatrician at Cincinnati Children's Hospital. I have nothing to disclose. So there are some learning objectives that I hope to accomplish in this presentation. At the end of the presentation, I hope that you will be able to define the term FASD, that you'll understand the underlying cause, that you can be familiar with the different diagnoses that fall under that diagnostic umbrella of FASD, and be able to describe some of the treatment options, understand some of the stigma associated with fetal alcohol spectrum disorder and how that creates a barrier for prevention and treatment. And then, because our group is sort of focused on the opioid crisis, I would like to describe some similarities and some differences between fetal alcohol spectrum disorder and neonatal abstinence syndrome. And as Steph mentioned, Dr. Kathy Wettig will be presenting on NAS, which is a withdrawal syndrome that can occur when someone is exposed to opioids in utero. That presentation will be in 2 weeks. So this issue has a huge scope. It is prenatal alcohol exposure is the leading cause of preventable developmental disabilities in the world. Within the United States, the prevalence rate is at least 1%. Some studies within certain populations within the United States have shown prevalence rates up to 5%. So this is a huge problem. Fetal alcohol spectrum disorder as a term describes an overarching kind of umbrella, if you will, to the range of effects that can occur when an individual is exposed to alcohol in utero. And these effects can be variable and can include physical effects, cognitive or brain-related effects, behavioral or mental health effects, as well as different learning issues, learning disabilities. Briefly, the first description of the possible effects of alcohol on the developing fetus was described in 1968. And in 1973, the term FAS, or fetal alcohol syndrome, was introduced in the medical literature. And then through the 70s, a lot of research was done that was able to unequivocally relate alcohol as a teratogen to the developing fetus with lifelong effects on children. And so the first public health warning was issued in 1981 by the US Surgeon General. After that, through the 70s and then after that public health warning, pediatricians became more aware of the symptoms and were watching out for these things, and became more and more reports were discovered of the wide range of effects that can occur after in utero alcohol exposure that may vary from mild to severe. And so the diagnostic categories were changed, and the term fetal alcohol spectrum disorder was introduced in 1996 to really denote that wide range of effects that can occur from mild to severe. Alcohol consumption is very common. Within the United States, 3/4 of people 15 and over report drinking some alcohol. And of adult women of childbearing age, more than half report some alcohol use, with 1 in 8 reporting binge drinking in the past month. It's important to keep in the context that 50% of pregnancies in the United States are estimated to be unintended, and that many people may be well into their first trimester before they recognize that they are pregnant. So I think those are important things to keep in mind as well. Within pregnancy, most women reduce or abstain from alcohol consumption, but 7.5% of pregnant women will continue to drink alcohol. That's what's reported in the literature, with 1.5 reporting that they have had a binge drinking episode in the last month. That is felt to be a gross underestimate because due to the stigma of alcohol consumption, particularly during pregnancy, it's felt to be quite underreported. So that is probably a very conservative, those are probably very conservative numbers. So when we just talk about the terminology of fetal alcohol spectrum disorder, the most widely known is fetal alcohol syndrome, or FAS. FAS is a very specific medical diagnosis. It's based on very specific criteria that include facial features, which I'm going to review in an upcoming slide, growth deficiency, so deficits in growth of an infant and child, and then specific brain structural and or functional differences. Most people with fetal alcohol spectrum disorder do not meet criteria for fetal alcohol syndrome. Only 20% will have all those physical features and the neurodevelopmental features that are required to meet criteria for that diagnosis. This is just a visual of that umbrella of fetal alcohol spectrum disorders, with fetal alcohol syndrome being the full-blown, meeting all the criteria diagnostically, and the others meeting just some portion of those criteria. And I'm going to talk about that in a little bit more detail, but it's just a visual for you what we're talking about with the umbrella. By no means do I expect or even think it's important for like detailed diagnostic criteria to be understood. I think what is important to understand is that there are various different terminologies that all fall under that umbrella, and they relate to meeting specific portions of those diagnostic features. So briefly, we talked about fetal alcohol syndrome in a previous slide, but there's also one of the other diagnoses is partial fetal alcohol syndrome. And that is used when an individual meets some of the criteria for fetal alcohol syndrome, but not quite all. There's also alcohol-related neurodevelopmental disorder, where the central nervous system effects are present from fetal alcohol exposure, but not all of the facial or growth features that are required. And then the least common is something called alcohol-related birth defects. And this indicates an individual that may have some of the physical structural anomalies that can be affected and a result of prenatal alcohol exposure, like congenital heart disease or cleft palate, but not the neurobehavioral or neurodevelopmental effects. The effects of alcohol in utero depend on the timing of the alcohol exposure, the amount, and the frequency, and there is a dose-related effect. This slide shows broken down into 3. So pregnancies are talked about as trimesters, and each trimester is roughly 13 weeks. And so the first trimester of pregnancy, alcohol exposure has been shown to have a particular risk for some of the major structural abnormalities that can occur in the developing fetus during that first trimester. And during the second trimester, there's been shown to be an increased risk of miscarriage. And during the third trimester, you can see that growth restriction, that growth deficiency. But I want to particularly point out this arrow underneath the visual here that says central nervous system effects. And this shows that the effects on the brain, both structurally and functionally, can occur through all 3 trimesters. So that's important to keep in mind. This is a picture of a child with fetal alcohol syndrome, so that full-blown FAS diagnosis, and the facial features include shortening of the palpebral fissure. The palpebral fissure is the distance between the 2 eyelids. So it's that, you can see the little line across the eye there. That's how that's measured. Actually, we use a little ruler in clinic to measure that if we're worried about FAS. And then the philtrum is the groove between the nose and the upper lip. And there are racial and ethnic norms that have to be taken into account. And again, there are diagnostic criteria for those. But the philtrum is very smooth in an individual with fetal alcohol syndrome. And then it also, the last criteria facially is a thin upper lip. Growth restriction is a reduced growth of the fetus and then also continuing into childhood. And as you can see, this is just an example of a growth chart of someone who has short stature, so some growth deficiency that's affected height in this case. And the little black dots signify where that child's weight, or sorry, where their child's height has been over time. And you can see it's at the very bottom, just hugging the bottom of the curve. The mechanisms of how alcohol affects the brain include direct effects on the structure of the brain, effects on the receptors that are important in signals being transmitted from one brain cell to another, the way they communicate with each other, and then effects directly on those chemical signals themselves, and those are the neurotransmitters. The effects on brain cell formation is decreased in general. So what the result is a smaller brain, what we might call microcephaly. So the brain is actually smaller than we would expect for the age of the child. And then there are some alterations in the specialization of cells. So as the brain is developing, certain cells will specialize for different functions, and that's altered with prenatal alcohol exposure. There's also differences in the way that brain cells move. As they develop, brain cells move from the inside out to the outside, and that migration is affected by alcohol exposure. And then disruptions in the little gaps between the brain cells that are called synapses, the formation of those is disrupted. And then brain cell death can be normal, it is normal, and it's called pruning, but it happens at an increased rate with exposure to alcohol. This is just a very striking example of two 6-week-old brains, the bigger brain being the brain of a normal 6-week-old, and then beside it, the brain of the same age child with fetal alcohol syndrome. And it's obvious to appreciate the difference in size, which relates to those decreased brain cell formation. And so thus, just this very smaller brain. But I also want you to just pay attention to the difference in the complexity between the bigger brain with all of the grooves and folds, and then the other one is just not nearly as complex. It just has not had that development. So the specific cognitive deficits include borderline to low average IQ. So typically IQs are commonly in the 70s to low 80s in individuals that were exposed to alcohol. And then attention problems, difficulties with attention focus, trouble with processing speed. So some difficulty with understanding and using information. Memory difficulties, so retaining information long enough to use it. Executive function problems, which would relate to the ability to organize and plan. Language deficits, both in understanding and using language expressively. And then difficulty picking up on appropriate social cues, which relates to just social interaction difficulties. It's oftentimes we can see sensory difficulties in individuals with a history of prenatal alcohol exposure, just sensitivity to textures, colors, noises, and then motor skill difficulties. You might have problems with motor coordination or reports from families that the child seems clumsy. There can be withdrawal noted after birth, and that might present as a newborn seeming more irritable in the newborn nursery. And then later in infancy, that might continue to a child being easily overstimulated, having some difficulty with coordination of suck and swallow, delays in those motor milestones of infancy, and being difficult to calm and soothe. As a toddler or preschool, children with a history of prenatal alcohol exposure often seem more impulsive and more active than their same age peers. They often experience more tantrums, both intensity and frequency and duration, than their same aged peers. And then developmental delays start to become more apparent in this age group. In the school years, kids with a history of prenatal alcohol exposure may seem younger than their peers. They have difficulty with memory, with short-term memory and working memory. They have difficulty with academic demands, and they may seem behind in physical and social development as well. And then again, difficulty with those social cues, which can create social interaction difficulties. 95% is reported to be the lifetime risk of co-occurring mental health conditions for individuals with fetal alcohol spectrum disorder. And the most common mental health difficulties that are reported include ADHD, anxiety, depression, and substance use disorders. I wanted to take a minute to compare fetal alcohol spectrum disorder and neonatal abstinence syndrome, which again, just as a little preview for what you're going to learn about in 2 weeks with Dr. Kathy Wedig. But both can have withdrawal symptoms. Fetal alcohol syndrome has distinctive physical features and growth deficiency. Again, that's the syndrome, not the spectrum, but the actual full-blown diagnosis of fetal alcohol syndrome. Has those very distinctive physical features, growth deficiency. But the central nervous system effects, like the effects on the brain structure and the brain functioning, so some of those cognitive deficits are better studied and documented with fetal alcohol spectrum disorder, where that is still being debated a bit in the literature and some conflicting results in the literature with NAS. But literature is strong for both on neurobehavioral difficulties for both children with FASD and NAS. Stigma is a significant barrier to prevention and treatment for both prenatal alcohol exposure and prenatal opioid exposure. And most importantly, outcomes for both are improved with supports, interventions, and appropriate services. Intervening early makes a big difference and is very important for this population of kids, with improved outcomes being seen medically, behaviorally, and vocationally by capitalizing on protective factors and on the individual child's strengths. Putting those supports and services in place really reduces the later risks of school difficulties, mental health issues, and future substance use issues. And that might include counseling, being involved in a specialty clinic where there's expertise in monitoring children with this issue over time, and then community and peer programs. The most treatment really for any kind of issue starts with understanding. And understanding the brain differences, understanding what fetal alcohol spectrum disorder is from a caregiver perspective, a medical provider perspective, an educator perspective, is really the first kind of step in treatment. Then developmental services, which may include therapies, including speech, occupational, physical therapy, may include behavior therapy, depending on the individual needs. Educational services are very important. Fetal alcohol spectrum disorder is not a unique qualifier for an IEP. These children are often served under other health impaired or some other qualifying diagnosis, but somebody making sure that the child is getting the school services that they need is very important. So that advocacy piece. And then treatment of the co-occurring conditions, the mental health issues that are very common to co-occur is important too. Stigma is a huge barrier to prevention and treatment of fetal alcohol spectrum disorder. There is a huge amount of stigma about alcohol use during pregnancy. And this, is really, I think, combated best by understanding some reasons why a woman might drink during pregnancy. And that may include alcohol dependence, which is a medical issue. Misinformation, there's a lot of misinformation still in the public about whether or not it's okay to drink certain types of alcohol. And by the way, they all have the same effect, you know, beer, wine, hard alcohol, but there's some misinformation that maybe beer is okay or wine coolers are okay, or that it's okay to drink during one, you know, certain trimester, it's okay to drink, you know, or that a certain amount of alcohol is okay. And there's also an issue of individuals perhaps being unaware that they're pregnant until, you know, well into their first trimester, for example. And then fear or shame is a huge issue as well. There are a number of evidence-based interventions, and I wanted to just, I got these from the Center for Disease Control. They have a whole great, you know, website on fetal alcohol spectrum disorder, and these are all fantastic, like evidence-based interventions. Project Good Buddies focuses on social skills training for children with FASD. There's a learning evidence-based intervention. There are parent-child working on behavioral regulation and executive functioning. And then there's specific safety training that's evidence-based for children with FASD. There's one related to behavioral problems for school-aged children. And then the last one mentioned here is an important one focusing on adolescents and young adults and reducing the potential for substance misuse in that age group. So I listed some references here, and I want to thank everybody for the opportunity to present on fetal alcohol spectrum disorder, and I'm happy to answer any questions.
Thank you so much, Dr. Pam. We really appreciate this overview. And I've gotten some ideas going in terms of differences with NAS. And one question I wanted to start off the group with is how we see a lot in practice of potential overlap with autism spectrum disorder. In your practice or in reviewing the literature, do you see commonalities with co-occurring autism spectrum in these kids? And maybe talk a little bit about that.
There are a lot of overlapping symptoms because you have the social features and some of the language and cognitive. But it's a qualitative difference in the social piece where, you know, it's more not misreading social cues, but having that level of interest, and then the lack of the repetitive behaviors and restricted interests is, you know, really the biggest difference.
Yeah, that was my understanding too around NAS, and that there's maybe some misperception because we don't have enough data around NAS and autism, but autism is 1 in 54. Mm-hmm. So I don't know, you know, we'll hear from Dr. Kathy in a couple weeks, but doesn't seem like there's enough data to say that there's more autism in kids with NAS. And like you're saying, there's a qualitative difference often in mm-hmm. kids with FASD that doesn't appear in children with ASD as well. So
can I just interject a little bit too?
Yeah.
So diagnostic autism clinic, we'll get referrals from children with both FASD and NAS where they do think it's autism. And sometimes they'll add in sensory concerns as the reason that they think it's autism or some unusual responses to stimuli. And then we start to dig in a bit deeper and we realize that there's a trauma history. I think it's also important for us to understand some of that overstimulation with the sensory that Dr. Ari Williams talked about. I thought that was important for me to talk back as well. But I do think that trauma, when you add that in, a lot of times folks who aren't familiar with some of those nuances will think that it's autism. I think a lot of those kids still benefit from a full developmental evaluation, mm-hmm. but I think that's where I think some of that comes in when you get some of those other complex issues as well.
Yeah, I agree, Andrea, because that trauma can come across as rigidity, need for control, wanting things a certain way, and that kind of speaks to some of those OCD-like autism spectrum symptoms, but there is that nuance difference. Yeah. Great. Other questions? I didn't see anything yet in the chat. Feel free to come off mute.
I had a clarifying question. I know you said early intervention is key in the long-term outcomes for these kiddos. I'm just curious if there is actual brain changes because of early intervention that we know of. I know there's probably not a lot of data, but just curious.
I've never seen any literature on that, brain changes related to early intervention.
It makes sense from an intuitive, that exposure to more and, trying to kind of improve that complexity in the brain, that it would make sense. Seems like something.
Yeah, the theory would support that. What I'm hearing from Pam is that there's not, at least known for this group, research. So are you in graduate school? Your dissertation may have just been identified.
Mm-hmm. I was also wondering, related to EI, is FASD a qualifying diagnosis like NAS is? I don't know if
It is not.
Okay. It's unfortunate.
Mm-hmm.
This is Stacy. I have a question about helping mothers with FASD parent. I wondered if there are any particular strategies, resources, or programs that will help some of our moms who were exposed to alcohol in utero better parent their own children.
Some of the evidence-based interventions that I had at the end, I think a couple of those were on parenting, but I think your question is if the parent has FASD, is that what you're asking? Okay, I don't know. Does anyone else know the answer to that? Anyone that is in the community? I'm not aware of that.
The only thing I can draw from is one of my colleagues does a lot of work around parents with disabilities and how there should be support through the county services for individuals with disabilities. And parenting is one of those activities of daily living. So it's not common practice, but I know that there's a push in the state of Ohio specifically due to a lot of the work from one of our colleagues, but also nationally to help support parents with disabilities, because too often we have, really sad stories of children being removed from their parents simply because the parent is blind, or simply because the parent has an intellectual disability, but doesn't negate the fact that they can still be a great parent.
Thank you.
So yeah, I think connecting to the DDS services could be one step. Not perfect by any means yet.
Yeah, well, and I think that raises a really good point with a lot of the moms that we all work with and interact with, because what we heard from Pam is that those IQs are in the 70s and 80s. So if we think about someone with an intellectual disability, it would be an IQ of 75 and below, and even that isn't always qualifying them for DD services. So how can we link with other, disability support? Sounds like really looking at kind of the Disability and Parenting Project, and some of the pieces might be a good first step.
I want to thank, I think it was Alicia who corrected me that it is a qualifying diagnosis through Hamilton County. So thank you, Alicia.
Okay, good. Yeah, and it looks like it is through the state, Ohio Early Intervention. Aaliyah put the list of qualified diagnosis on there. So that's at least good. So, and maybe and I don't know if we have any EI providers, but I wonder, when we think about ways to support the moms, could it be something where the individual family service plan has some things that are work towards parenting resources for the mom, if we recognize that? Now, the child may not have it if mom has it, I guess, but I think being aware of mom's challenges within the EI program could be helpful too.
My other thought would be to consult with a psychologist for some testing, just to formalize and get really specific around what is mom's needs, because that certainly would be a way you wouldn't need a qualifying diagnosis in order to get recommendations. So
That's a good idea. Some of the moms that we have, they mentioned that when mom is an alcoholic, but they don't have any formal diagnoses. They may have had an IEP as kids, and then some of those moms get very easily frustrated and overwhelmed in that early period with a lot of crying with baby, and it's kind of scary time. So yeah, that's a really good idea to get a formal evaluation, and almost all of them are on Medicaid, so
That
that
should be,
free.
yeah.
Mhm.
Yeah.
Thanks for bringing that up, Stacy. That's really important in supporting families. Pam, there's one other question in the chat about the effects when a mother didn't drink during pregnancy, but drinks and nurses, and does quantity and frequency in that matter during nursing?
It does get into breast milk, so the recommendation is not to drink alcohol, but there hasn't been good literature on effects on, you know, infants who were exposed from breastfeeding. The amount would be less than, because it's going to go through the digestive system, it's less than like directly from the placenta to the baby, but there's no known safe amount of alcohol exposure for the developing brain. So the recommendation is not to drink alcohol during breastfeeding. But I haven't seen anything about particular studies only limited to the breastfeeding period.
Thank you.
One of the challenges I've had working with parents, especially adoptive parents of children with FAS, is I think there's a poor understanding that this is lifelong and that developmental delay services aren't going to take away you know, the results of fetal alcohol. And I'm wondering how much those of you who are working in practice with them are explaining to parents that this is lifelong, this, you know, that there are always going to be issues, rather than them thinking that, okay, we know what it is, now we'll get all the therapy and it will go away. Because I've even had people working with the child in the home providers, who are calling me saying, well, we need another diagnosis because these behaviors are continuing. It's like, well, they're going to. I mean, there can be some improvements, certainly, but I really don't think people understand that, you know, the treatments that happen to assist these kids are not going to take away the fetal alcohol syndrome. Just any thoughts, any discussions you're having with parents about that?
I think this gets back to the understanding piece and the education piece when talking to families or other caregivers, or is just being really open about that there isn't a cure for fetal alcohol spectrum disorder, but that certainly treatments and supports can, you know, have improvements, but that there isn't any like cure for this, and that most individuals do have some kind of issues long term, but we want to reduce the risk of that by intervening early. I try to be pretty open about that with hope, but also just being honest about what is known about fetal alcohol spectrum disorder. What do other people do in conversations with families?
Yeah, I agree that I think transparency is important, but I also think it's always a challenge with providers to provide hope as well. So I like to say the hope with it, talking about change and, you know, that's the frame that I use with a lot of developmental disabilities when I talk to families, is this is a lifelong neurodevelopmental disorder, but with intervention, you can provide the supports that are going to let them be able to lead the fullest life that they can. I think one of the other things that I really try to be mindful of is people use the word delay a lot and talking about a delay. And when children are younger, we use that a lot, but you see some people hold on to the word delay, and that it can be very confusing to parents, right? Because a delay implies that you're going to catch up. And so thinking about when, and that's where I think having an ongoing relationship with, you know, a nice medical home with physician or someone who's with the family ongoing, who can kind of help them move through the process of these things. Okay, it's considered a delay, but you know, now he's 7 And this is what we're looking at. And really that kind of having that developmental approach with the parents, I think is really helpful too.
Andrea, we get to work with moms with the babies that are very young. And so one of the things that
I'm sorry, whoever is speaking, you're really, really hard to hear.
Hi, it's Twinkle from Moms.
Oh, there's
TV.
Twinkle. Hi, Twinkle. Thank
Is
you.
that better?
That is better.
We work with babies that are really young. And so one of the things I remind our moms are we can't go back and change what happened during pregnancy. We can only move forward from here, because for any of us who have a child with disability, we're always guessing or re-guessing or rethinking of what we could have done differently, be that alcohol, drugs, or anything else. And so helping them to realize that we can't change the past, but we can make small steps, and just looking at it as a small step. And because if they lose hope now, they'll never get it back. And we as providers have to pour hope into them every time we see them, no matter how small it is, because it's vital for everyone's success.
Yes, thank you, Twinkle. And I love the chat that's going on, so please make sure you check that out. In the interest of time, we're going to move to the case discussion. So thank you, Dr. Pam, for your wonderful presentation, which led to this rich discussion. Wonderful, and such a great addition to scope. I think there was one quick question about alcohol plus other substances, heroin, marijuana, meth, during pregnancy, and is there an alternate diagnosis that looks at the bigger picture? And in general, neonatal abstinence syndrome would be the diagnosis that reflects that bigger picture. Neonatal opioid withdrawal syndrome is a newer term that is looking specifically at the effects of opioid withdrawal. However, there's not a lot of literature that says individuals don't have polysubstance use in pregnancy. So it's really hard to tease out that it was just opioids. So I think what you're getting at, Deborah, is the alternate diagnosis would be neonatal abstinence syndrome at this point. So thank you for putting all of those great comments in the chat box.